This is Dr. Christopher Sendy with Nova Health Recovery Ketamine Infusion Center. I'm going to discuss ketamine therapy for anhedonia, which is effectively no mood at all. So what is anhedonia? Anhedonia is defined as a diminished pleasure from or interest in previously rewarding activities. There are no therapeutics currently approved for the treatment of anhedonia, and half of the patients diagnosed with bipolar disorder experience significant levels of anhedonia during a depressive episode. Now, anhedonia is a significant side effect of traditional antidepressants. You may be less sad and tearful when you get treated with your antidepressants, you might not cry as much, but you kind of lose your joy in life and the hope for the next great adventure. So basically, you're just emotionally blunted, you just exist. And individuals just do not like the feeling of anhedonia because there's just no excitement in life. And again, this is a construct of depression, but it's also a side effect of traditional antidepressants. And there are no current treatments for anhedonia. Standard treatments for depression do little to alleviate anhedonia and may even cause reward and emotional blunting as well as sexual anhedonia. And these are traditional side effects of regular antidepressants. The presence of anhedonia in a major depressive episode is actually a predictor of proximal suicide completion. So individuals with anhedonia are more likely to have completed suicide. Anhedonia in patients with affective disorders also have a poorer treatment prognosis than depressed patients with no anhedonia. So anhedonia itself is a sign of a more difficult treatment-resistant case of depression. And we know that from other studies that anhedonia predicts poor recovery among young people with SSRI inhibitor treatment-resistant depression. So young individuals taking SSRIs with anhedonia basically have poorer recovery from their depression. And multivariate analysis examining all 5 depression symptom dimensions simultaneously indicate that anhedonia was the only dimension to predict a longer time to remission and the only dimension to predict fewer depression-free days. So if you have anhedonia or no mood or basically just emotional blunting, then you are more likely to have fewer days without depression, and you're also going to have a longer period of depression before you get remission. And where is the basis for all this? Well, the NMDA receptor, which we've discussed in other videos, is a key part of this whole process. The NMDA receptor is present in the cortex of our brain, as well as throughout the spinal cord. And it's been discovered through a number of studies that the NMDA receptor and glutamate system play an active role in depression and probably also in anhedonia. And there are certainly other videos that we discuss the actual NMDA receptor and what it does, but effectively ketamine interacts with the NMDA receptor, basically blocking it. Excess activity of the NMDA receptor can cause a number of situations of neurotoxicity and other disorders in the brain. So what are the components of anhedonia? Anhedonia can be subdivided into 2 components. There's a consumatory part, which is like the subjective pleasure. For example, enjoying food or being at the beach. So even if you're depressed, just suddenly placing you at the beach without any effort, you might actually enjoy it. If I gave you a steak, you might enjoy it. Or even reading a comic book, you may laugh at the comics. So basically consuming the actual reward is fine. But the motivational components, the anticipation of a drive towards a rewarding stimuli, for example. For example, going to the beach, it can be just overwhelming because you have to get all your stuff together, pack up the kids, and put the dog in the kennel, whatever it might be. And planning and looking forward to the vacation, for example, just there's no motivation to do that. So basically with anhedonia, a lot of times there's a motivational problem. And so basically we have consumatory parts for anhedonia and motivational components as well. And currently depressed, major depressive disorder patients and bipolar depressed patients generally possess a substantial deficit in motivational rewards, but not consumatory reward behaviors. So in other words, they can enjoy things if it's just handed to them, but the whole concept of going out and getting them is really what the problem is for the majority of patients. And so it's been seen that depressed patients experience the same levels of pleasure as healthy volunteers when they view, for example, humorous cartoons in a computer task, but they were less willing to exert as much effort to gain access to these stimuli. So just the whole idea and energy taken to go get these particular enjoyments is just not there. And so the results again suggest intact consumatory processes, but attenuated motivational ones. And these are actually different areas of the brain. So in particular, one area that people forget about is the habenula, and in particular the lateral habenula, which plays a significant role in a number of different reward processings and negative thinking. And studies in regards to this area recognize that the habenula works in tandem with the midbrain dopaminergic neurons, which are involved with motivational constraints. And again, during the processing of reward and punishment, basically this area of the brain is involved with signal prediction errors that arise when the reward expectations are violated. So in other words, if I expect that when the bell rings that steak is going to come and it doesn't come, then this is a role for the lateral habenula, which is a critic of your value-based decision making through its connections with the dopamine system of your midbrain. So again, like Pavlov's dog that's been trained to respond to the bell ringing, basically if the bell rings and I don't get my steak, then basically my lateral habenula is going to react to that in a negative way. And the habenula and midbrain dopamine neurons and their connectivity are important for value and salient signaling. Salience being, the attention to current events in the environment that represent a positive or negative type feature of something good or bad. And this can be relevant to anhedonia. So what was found is that direct injections of ketamine into the lateral habenula suppressed the burst activity of neurons in this region, and they produced a behavioral antidepressant effect in rodent models of depression. So excessive activity of the lateral habenula seemed to increase depression. And therefore, the NMDA receptors play a role in the burst firing of the lateral habenula neurons and raise the possibility that ketamine may alleviate symptoms of depression through the direct action on the lateral habenula. The fact that standard antidepressants lack any proven anti-hedonic efficacy, particularly in conjunction with the deleterious side effects associated with these agents, kind of requires novel pharmacotherapeutic approaches. So we need to have new treatments to address anhedonia, which is a significant component of depression. And we know that ketamine effectively treats depression and bipolar depression. And there's a number of studies that have been out starting in 2000 with Berman and Crystal and his group with their small studies, and then replication studies as well. So we know that repeated infusions of ketamine through Moreau's studies in 2012 demonstrated efficacy as an antidepressant therapy, and that Zarate in 2006 replicated Berman and Crystal's initial trial for ketamine therapies for depression, and that basically ketamine is effective for bipolar depression in a randomized controlled add-on trial in both Diaz-Granados studies in 2010 and Zarate in 2013. And that also there were further studies with Ibrahim in 2012 and Moreau in 2013 that repeated ketamine infusions decreased depression in individuals with treatment-resistant depression and even bipolar depression. So ketamine is an ideal agent to help treat anhedonia. And subanesthetic doses of ketamine acutely increase glutamatergic and dopamine signaling in the prefrontal cortex of rats. And this was noted in studies by Dr. Mogadam, 1997. And so there seems to be a role of dopamine and glutamine signaling that mediates anhedonia and the reported pharmacological effects in both rodents and humans. Ketamine is really ideally suited to ameliorate anticipatory anhedonia in currently depressed patients. So those patients with anticipatory reward problems with anhedonia and they're depressed, ketamine may be an effective tool to treat that. And the glutamate system and its downstream modulation of the dopamine system may be the route by which ketamine works for anhedonia. So there was a trial by Lally and his group in 2014, in which they used a randomized, double-blind, placebo-controlled crossover study to assess the antidepressant efficacy of ketamine in treatment-refractory bipolar depression. And what they did is they took 36 patients, and these individuals had not responded to mood stabilizers such as lithium or valproate at treatment levels. And they applied to them one dose of either 0.5 milligrams per kilogram of ketamine or a saline solution over 40 minutes. And then 2 weeks later, gave them an infusion of the other side of saline or ketamine, the opposite. And in order to basically participate in this trial, they used the MADRS score, which if it was greater than 20, then they would be able to participate. And then they measured the clinical ratings at specific time periods as far as 14 days later after the infusions. And they also assessed anhedonia through something called the SHAPS test, which is a 14-item self-administered test. They also did use some brain imaging as well to assess glutamate receptors in the brain. And what they found was that ketamine, compared to placebo, rapidly reduced levels of anhedonia in these patients. And the reduction occurred within 40 minutes of a single ketamine infusion and lasted up to 14 days. And that the anhedonic effects of ketamine remained significant even when depression was not improved. So anhedonia and depression seem to be separable conditions. And so ketamine basically has a unique role of ameliorating anhedonia levels independent of other depressive symptoms. So they also found that through the brain imaging studies that anti-anhedonic effect was mediated in part by increases in glucose metabolism in the dorsal anterior cingulate cortex. And they know that both the dorsal anterior cingulate cortex and putamen are highly involved in reward processing, learning, and decision making. And one last fact was that after ketamine infusions, individuals taking lithium experienced greater anhedonic effects than those receiving valproate when the antidepressant effect was controlled for. Another study of repeated ketamine infusions for treatment-resistant depression was with Wilkowska's group, in which they utilized basically a series of ketamine infusions as add-on treatment for 42 patients with treatment-resistant depression, and used the SHAPS score as a measure of response, and found that basically the repeated ketamine infusions allowed for depression decrease as well as anhedonia decrease 1 week post-treatment in particular, but they noted that patients who used benzodiazepines had less of an effect. So ketamine therapy is an effective option to treat anhedonia. Traditional antidepressants are associated with side effects of anhedonia, and depression is associated with anhedonia. Anhedonia is difficult to treat, and it's associated with higher suicide rates in some populations, and also results in low motivation and loss of quality of life. Ketamine therapy is the only effective treatment seen thus far in both clinical and research setting, and generally 6 infusions over 2 weeks demonstrate the better outcomes, and maintenance infusions, potentially monthly or home-based ketamine treatment options, may allow us to maintain effects.